Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Helping Alabama Stay Healthy Through Assessing for Substance Use, Screening, Brief Intervention, and Referral to Treatment. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in this program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. Please note that continuing education for this program is being offered through the Deep South Center for Occupational Health and Safety and will not be offered through ADPH. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation to the Deep South Center. Both documents should be sent to Paulisha Holt at pholt@uab.edu. Please make note of this and do not send your documents to the Alabama Department of Public Health. While content may continue to be relevant, continuing education will only be awarded until the provider expiration date on January 3rd, 2019. We hope to extend that expiration date after the Deep South Center is reapproved as a provider of continuing education units, and will update the flyer and on-demand page if that date changes. Now, let's meet our presenter. Suzanne Fogger is a professor at the School of Nursing at the University of Alabama, Birmingham. Welcome, and thank you for joining us today.
Thank you. I'd like to introduce myself real briefly. I'm a psychiatric nurse practitioner. I'm also an addictions nurse, and I have a practice within the UAB system. I teach at the School of Nursing as a professor there. What I'm going to talk to you about today is not of any conflict of interest in terms of anything that I'm involved in, but what I hope to do really is to talk about how substance use assessment can be incorporated into any particular field of health, looking at both public health and primary care because it's very applicable. We're going to talk about how SBIRT, which is screening, brief intervention, and referral to treatment concepts work. Talk about screening tools that you can incorporate into your practice, and the screening tools are readily available through Googling them, and you can download all of these tools. SAMHSA is also a great place to get the tools from. And we're going to also talk about methods of assessing for substance use without disengaging your patient. So those are our objectives for this particular presentation. And in the process of doing so, I'd like to introduce to you a real brief video that can be found on YouTube that is a synopsis of SBIRT and what it can do. Once you have watched the video, we'll come back and go through these elements. So here we go.
We all know alcohol and substance misuse is a problem that affects many people. When you consider the number of people affected, changing those numbers might seem insurmountable, but it's not. As healthcare providers, we are perfectly positioned to do something about it. That's why we all need to be skilled at identifying and addressing risky alcohol and drug use. Wait, aren't these things somebody else's problems? Furthermore, why should we care? First, we should care because alcohol and drug problems are common. Studies have shown the prevalence of substance misuse is higher than what we're currently addressing. Our primary focus here is the 20% of people who are at-risk users. These users include the 1 out of 6 patients you see that has had at least one episode of binge drinking in the past 30 days. 1 out of 12 patients meets the standard diagnostic criteria for an alcohol use disorder, and 1 out of 50 meets those diagnostic criteria for a current drug use disorder, including illicit and prescription drugs.
Oh, but I don't have any of those people where I work.
Think again. We all see patients who have these problems, even though the problems are often hidden. Why should we care? Because alcohol and drug problems are serious. Alcohol and drug problems cause or complicate a lot of chronic diseases and acute problems. Half of all trauma center visits are alcohol-related. And substance misuse increases an individual's risk of several chronic diseases. Chances are you're already working with these people. Furthermore, alcohol consumption results in over 100,000 deaths each year in the U.S. and ranks third in preventable deaths, following tobacco and poor diet and inactivity. Why should we care? Because alcohol and drug problems are also expensive. Substance abuse is a problem that everybody pays for. Federal and state governments spend at least $373 billion a year on substance abuse. That's $1,486 per person in the U.S. Furthermore, of the total substance-related spending, less than 2% is spent on prevention and treatment, while almost 96% is spent on the collateral damage from alcohol and drug abuse. Shoveling up this wreckage puts a huge strain on the budgets of much-needed programs, including government-funded health care, which must cover most of the burden. This cost is funded by your tax dollars. Okay, so these problems are common, serious, and expensive. So what? There's nothing I can do about them anyway, right?
Actually wrong. There are things you and I can do that make a difference. SBIRT is a proven method for addressing substance misuse in routine medical care. It stands for screening, brief intervention, referral, and treatment. With SBIRT training, small conversations result in big impacts.
The first and most important step is screening for risky behavior. A person doesn't have to be addicted to be in a risky category, and any use of tobacco, illicit drugs, or prescription drug misuse is considered risky. Solid population-based evidence sets low-risk drinking limits for men at no more than 4 drinks in a day and no more than 14 in a week. For women and for men over 65, low-risk limits are no more than 3 drinks in a day and no more than 7 in a week. A lot of people are surprised at how low these limits are, but the science is solid. Anything more than these limits is a positive screen. And with a positive screen, it's time for a brief intervention using motivational interviewing techniques. But that conversation would just be too uncomfortable. My patients would just lie. They'll think I'm accusing them. But the vast majority of patients say,
my doctor should feel free to ask me how much alcohol I drink.
If my doctor asked, I'd give an honest answer.
If my use affects my health, my doctor should advise me.
Moreover, there's good evidence from many randomized clinical trials that if we just talk with the risky user about cutting down or quitting, 20 to 30% will do it. These conversations also reduce the risk of another ER visit for trauma.
As you've seen, most of the time and energy put into substance misuse is responsive, reacting to the physical, social, and economic consequences. SBIRT is changing all that.
Instead of cleaning up the wreckage, we're getting in front of the train and steering it along a safer route. Learning a few simple skills can make these conversations quick and comfortable for you, and more importantly, helpful for the patient.
If you are interested in learning more about SBIRT, please visit this website.
Thank you. That brief video covered many of the principles that we're going to talk about during this particular presentation. So let's go ahead and get started. The high-risk behavior we're looking at today is focusing on alcohol. However, SBIRT is also effective for screening for tobacco as well as other drugs that people may be using. And as they said in the video presentation, part of our goal is to make screening for risky substance use a routine part of medical care. so that when folks come in for treatment, for any particular reason, that part of the process is that they get screened to see how they're doing in terms of consumption of various chemicals. So many times people have no idea if they're drinking above the goals of safe alcohol use. So why assess for substance use? It is very difficult to try to control and help people control their diabetes, hypertension, their obesity, and their risk for fall if they continue to drink alcohol at a level that's above the risky level. So it is helpful to ask folks who have these chronic illnesses, are they using alcohol, and if so, how much are they having, and when are they exceeding the healthy alcohol use? Hypertension and diabetes are better able to be controlled when the substance use is within a period in a safe zone as opposed to into the risky zone. If one considers that assessing for these things can help you and the patient reach these particular health goals. So in the framework of looking at SBIRT, it is important to keep in mind that this is about health-damaging behavior and helping people to see that they have an issue, because people who are not ready to change have been shown to leave treatment early or not even engage in treatment if they can't see that they've got an issue. That I imagine that if you keep in mind the last patient that you tried to work with who had either a tobacco and alcohol problem, who wasn't ready to make the change and forced into it, they may have used their feet and left as soon as they were able to. So the strategies we're looking at today are helping people to change and understanding where they are in the readiness for change, because as healthcare providers, we can help people become more ready for change by providing information to them that'll help them make rational decisions. So it is helpful to consider what kind of reinforcement that the individual may have in shaping their behavior. These are examples of two different types of reinforcement. The first one is positive reinforcement, in which the individual may get positive reinforcement that keeps the behavior to continue from happening. So this example of the instructor praising the student for doing well, the student would continue to do that behavior because of the fact that they're getting positive reinforcement for that. So if you switch this to alcohol, alcohol is a positive reinforcer because when people drink, they feel good, they enjoy the feeling that they have when they drink, and so that's a positive reinforcer of that particular drug. Now, on the other hand, the negative reinforcer would be that if a person has negative consequences, that when they have studying to get the teacher's attention, the teacher does not scold them, and that is essentially doing something to avoid the negative. So this would be negative reinforcement. In this particular case would be that people drink to avoid feeling bad, that when people are upset and stressed that they drink. So these two concepts, negative and positive reinforcement, is helpful to know what it is that attracts people to using alcohol. Is it because they enjoy the feeling that they get when they use, or is it because the negative feelings that they have, the only way that they know how to deal with them is to use the alcohol? And both strategies are really important to understand what it is that gets the person using. The second one, with negative reinforcement, the treatment might be to help the individual see other ways to manage those feelings as opposed to using the alcohol. So the history of SBIRT, it's not been around for a really long period of time, perhaps for the last 30 years or so, with the original studies being done in Europe. This initial study that I'm talking about here was one in which a primary care doc said to his patients, and they had a very select group of men who were engaged in very heavy daily drinking, and that over a 2-year to 6-year period of time. So this is not something that takes place in a short period of time, but one that is reinforced every time that the people come in to be visited, that they decreased their alcohol consumption and they were able to avoid negative medical social consequences and decrease their overall mortality. So by helping these people focus on the fact that their drinking had consequences, they were able to cut back. It didn't say that they quit drinking, but they cut back on their drinking so that the negative consequences didn't occur. The other piece that happened during this period of time was that there become reliable screening tools to assess people in a consistent way to determine whether or not people have an underlying substance use disorder. Because a person drinks heavily doesn't necessarily mean that they have an alcohol use disorder. It might be that they have heavy alcohol use. So one has to be careful in terms of what terms we use, but the important piece is that we assess for what they're doing now and helping them to move to using less. So the screening is considered a way to identify people who have risky patterns of use. It doesn't give you definitive information, it doesn't give you a diagnosis, but it does help move you toward what treatment options that this individual may benefit from, because not all patients need inpatient care and not all patients are going to respond to counseling only. So in the process of screening, it helps you to determine what level of intervention this person may eventually need. So the brief intervention part goes back to the motivational interviewing piece. This is usually a single session initially, or multiple sessions depending upon the individual, in which motivational discussion focusing on the increasing the patient's insights and awareness into their substance use, which is a very subtle way of doing things so that the individual recognizes their underlying issues of substance use and they choose to move toward making behavioral changes. So some of this is not necessarily telling people you must cut down, but to say to them, what do you think about the fact that I just told you that you're drinking above the safe limits? And allowing the individual to begin to make thoughtful decisions about what they might want to do about that. So the referral to treatment piece is to help to decide where you want to have this person go for additional care, to work with the individual to essentially do similar to a warm handoff, where you connect this person to other providers who can help this person learn different skills, to learn how the substance use has been affecting them, and to find other ways to manage their life without the use of the substance. For some people, this may mean that they go into inpatient care, it may mean that they go into intensive outpatient, and for some folks, they respond to the brief intervention and reduce their drinking without any further problem. So the referral to treatment piece may come after you have continued to work with them with MI and find that they, because of the fact that they have a substance use disorder, are unable to do it themselves and require additional professional help. So this is not a 1, 2, 3, 4 thing that happens in the course of a day, but may take place over time, a series of visits, or may be compressed and take place over a very few visits depending upon the illness that the individual has and the degree of urgency that is apparent. So common assumptions about health behavior changes. And the first being that providers many times believe that this person really ought to change, that they have behaviors that are causing them problems, that they really should be ready to change, and that their health is going to be a prime motivating factor for them or for him or her. And as many of you as providers know, just telling the person that your cholesterol is very high and that your blood sugars are in the range in which you're pre-diabetic, many times people don't necessarily make the changes necessary to alter the trajectory of that disease process. One of the things that unfortunately people perceive is that providers take on the sense that they have failed when people choose not to make changes, that somehow or another, if I didn't structure it differently, that this person would do what I suggested they do. But I am encouraging you, as you try SBIRT and as you incorporate this into your practice, that you consider that this is about helping the individual make the changes and see the changes themselves, but as a professional to guide them, but the growth and the change that goes is theirs. It is about you to be alongside of them as their assistant to help them ID the change that they want to make and then move through the process, but you cannot change them. It's kind of like the concept of how many psychiatrists does it take to change a light bulb? None, because the light bulb has to want to change themselves. It's an old joke, but something that might lend itself to this situation. Now, in looking at the spectrum of alcohol use, the issue is that for years we've focused on the top section of the pyramid. SBIRT is really looking at the middle section of the pyramid, the top 25% or 20% of individuals who have at-risk drinking and who, if the trajectory of their drinking can be altered, that it is conceivable that the down-the-line consequences of heavy alcohol use can be avoided, that individuals can make changes to their life so that they don't end up in the dire consequences of entering into substance use disorders or alcohol use disorders. So this is more about helping people at a lower level of the pyramid to recognize that they can do things to change. I'd like to point out in this pyramid that there are people in the world who don't drink at all, and there are people who drink moderately. The issue is that folks who drink heavily believe that the rest of the world drinks like they do, and so it's inconceivable that anybody doesn't drink. Some folks do not drink, and that is the purpose behind the SBIRT, is to kind of begin to have a dialogue with people and to talk about what standard is. Now, this is a standard drink scale, and you can print this off. It's available online through SAMHSA, in which, as you're talking with your patient, part of your educational process is to talk about what a standard drink size is. Because I, as a woman, 3 drinks per day would be the maximum that I could have, but to clarify how big that drink is important. Because there are some folks who, when you ask them how big their beer is, they're drinking the ones that are 24 ounces, so when they have 3 beers, they're really having 6 beers. And that for some folks who, when they pour themselves a glass of wine, the glass that they have holds almost the entire bottle. So having them discuss what size glass they're using as well as how they're counting, because what they are saying and what you are interpreting needs to be clarified, that you're both on the same page. The other piece is that to clarify what a standard drink is so that they understand if they're using a measuring cup that holds 2 cups of liquid, that's far and exceeding what a standard drink size would be. So briefly, alcohol facts, that 84% of the people over age 18 report they drank some alcohol in their lifetime. That 26%, or about a quarter of the people in the United States, have had some binge drinking in the past month. And 7% report they engage in heavy alcohol use in the past month, which would be people who report they've exceeded the more than 4 drinks in a single setting. So the number of people we're looking at are probably the 26.9% of the folks 18 and older who are binge drinking that we're looking at, seeing if we can't alter those particular folks. So of the number of people in the United States who have an alcohol use disorder, it runs between 6.2% and 8.4%. Men, more than women, have an alcohol use disorder. So when you're screening people, one would anticipate that you would have a larger number of men who use alcohol than women. However, one of the things when you're looking at adolescents, age 12 to 17, the surprising piece here is that the number of adolescents who have an alcohol use disorder, there are more females than there are males. And part of this gets back to this concept of what is the motivator for it. And many girls have been found to drink more to deal with the negative reward of alcohol, which is they drink to make the anxiety and the depression go away. They drink to relieve the stress. So I point this out because these folks are not even eligible to be drinking, but at the same time they have managed to get a hold of alcohol and drank enough to enter into an alcohol use disorder at a very young age. Of that group, it's a small group, only 5.2% receive any treatment at all. So asking as you're working with teenagers, do you have a drink now and then, or do you drink alcohol? Have you had more than 3 drinks in any one setting? Even though they're not old enough to drink legally, that doesn't mean that they're not. So when you're seeing teenagers, please assess them for alcohol use. So the definition of binge drinking, so we're all on the same page. For men, it's drinking more than 5 drinks in a single setting. For women, it's more than 4. The rationale for why women have fewer has to do with the body composition, in which men have a higher amount of muscle and women more fluid and adipose tissue, so that it takes less to reach a toxic state. The other piece to that is that women have fewer enzymes in their stomach to break down alcohol than men, so they're at a disadvantage on several different levels. So binge drinking, more than 5 drinks in one sitting, women more than 4 drinks. Many folks who celebrate football occasions frequently may be having episodic drinking. So asking people about, do you have that issue? And if using before age 15, this individual is 4 times more likely to have misuse problems as an adult compared to an individual who begins after the age of 21. So when talking with adolescents, to let them know that they have choices that they can make, that it's important that they delay using alcohol until at least after age 21 so that their brain can mature, because early use of alcohol increases their likelihood of problems and also decreases their brain's ability to myelinize, so that their thinking processes and problem-solving skills may not be as fully developed as if they had not used alcohol until well after these areas of their brain finished forming. So helping people to see that there is a choice. So this particular slide, although tiny, says, how does heavy drinking move to addiction? Drugs are reinforcing because they either add pleasure or they reduce pain, which is the reward. They give pleasure or reduce pain. This reinforcement increases the likelihood that people keep using. So if the only way that you know to relieve stress from work, or the only way that you know to relieve the worry of the fact that you can't make the bills is to drink, then that reinforces the fact that drinking makes me feel better. And so as a person drinks more, they develop a tolerance. A tolerance and dose escalation just means that the same amount of alcohol that it took to get me into a state of relaxation, calmness, pleasure, a buzz, is going to increase. So before it might have taken 2, now it takes 4, and so the dose keeps going up as the person's tolerance increases. Now, as their tolerance increases, the potential for withdrawal increases. And withdrawal does not equal a use disorder, but it would be suggestive of the fact that they have had repeated episodes in which they drank a considerable amount. Withdrawal is where their brain has become used to having that much chemical on board, and when that chemical ceases to enter into their system, the opposite happens, and as opposed to a calming effect that they have excitation, in which their blood pressure will go up, their pulse goes up, and they feel anxious and shaky. And so it motivates folks to reduce this unpleasant feeling, and so the answer to it is more of what helped them in the first place, more alcohol. So over time, the brain shifts control from deciding to drink or deciding to use to the fact that I have to avoid the withdrawal symptoms, to avoid this negative feeling that I get when I'm not using. And this is essentially how the cycle of addiction gets started. That people initially make choices, but once they get into it and have reached tolerance and beginnings of withdrawal when they stop, that there is no other way for them to feel halfway normal than to return to using. So the 4 C's of addiction, to understand the spectrum that we're working on today and looking at use, misuse, and addiction, the 4 C's of addiction include loss of control, which is an individual sets out to drink 1 or 2, and they end up drinking as much as they could possibly hold until they no longer are conscious. So loss of control is one of the 4 C's. Compulsive use, that they feel that they must use and don't have a whole lot of decision-making processes if I choose, but I have compulsive use, I have to use. Continued use despite harm. As you're beginning to see, this is hitting on some of the requirements for the DSM-5 for substance use disorder. The continued use despite harm could be social harm, in which the family is upset when I use, to the fact that my liver function tests are beginning to elevate and that when I drink it is causing me additional problems physically. And I've been advised to stop using, but I continue to use despite the fact that I'm aware of my drinking or using continues to harm. And the 4th C is craving, in which the individual's brain, having been addicted to this substance, uses and sends out messages, gotta have, gotta have, gotta have, so that this tape loop, in essence, of needing this deep, unsatiable feeling is part of the craving process, which is very, very hard to ignore. So addictions is a chronic disease, and it is helpful to think about it that way. It is similar to diabetes, to hypertension, to the fact that when a person reaches into having a use disorder of a certain type, that it is about the fact that the brain and the circuitry has been rewired, that the dysfunction in these circuits leads to a characteristic biological, psychological, and social manifestation, so it affects all aspects of a person's life. And they may pursue the reward and relief of the substance at the risk and the loss of all other things. So addiction is not logical. It is a sense of a brain disease in which the individual, once they enter into addiction, no longer has the choice of pursuing or not pursuing because their brain has indeed been hijacked. So the neurotransmitter that is primarily involved with this is dopamine. And in this particular sense, dopamine is less about pleasure and more about novelty detection, looking for excitement to learn, and incentive salience, in which the alcohol takes away from the pleasure of doing other things and it takes over. So the prefrontal cortex of the brain is your learning about things, a deciding, decision-making process, and in essence makes the decision to approach or avoid. And the drugs trick the brain into thinking that they're very important, that that is something that you need to have, that as opposed to the importance of going to church or going to my child's soccer game, that I would prefer to use because the drugs have tricked the brain into thinking that these things are more important than anything else. So getting back to screening, now that we've kind of talked about one end of the spectrum about alcohol use disorder, going back to looking at unhealthy alcohol use, because we're trying to essentially change the trajectory so that people don't end up over here, is by asking a single question. How many times in the past year have you had X or more drinks in a day? And the X part is if it's a woman, you would say 4. If it's a man, it would be 5. So you're getting at the binge use disorder question. And if they say, every time that University of Alabama played football, so far maybe 6 or 7 times this year. So the bottom line is more than once is a positive response, in which you would go on to additional screenings. So some people, remember, don't drink at all. So they would look at you and go, never. And you'd let it go. Further exploration about alcohol use, if they say never to this, is you've done what you need to do. They don't have unhealthy alcohol use. So screening tools, you've got a couple of them that you can consider. This DAS is a drug and alcohol screening tool. You can get that online from SAMHSA. You can put in under Google drug and alcohol screening tool, and it is available and easy to use. You can just print it out. Many of these tools can be self-administered by the patient so that you can have the opportunity to look at their answers before you set in to see them. So several of them, which are well known, include the audit, which is a 10-item test question in which each area is scored on a 0 to 4, and if an individual scores in a certain level, it is consistent with alcohol dependence or unhealthy alcohol use. These are options that you consider. Many people use an audit C, which is the shorter form, and this is the shorter form right here. 3 questions, relatively easy to answer. The person can answer them and you can move on or begin to get a feel for their use. So the first question is, how often have you had a drink containing alcohol? Pretty often, every night. This gives you an idea about how often. How many drinks containing alcohol do you have on a typical day when you're drinking? So this gets at the binge drinking question. And how often do you have 4 or more drinks, 5 or more if you're a man, on one occasion? So if they end up screening positive for this particular test, you'd go on to the audit, which has got 15 questions to it, which gives you a little better definitive response to how a person's drinking. You could use these, and because they're relatively easy and fast to use, they are highly recommended. The CAGE is one that many people have been exposed to when you're in school. The issue with the CAGE is that if a person screens positive on this one, it's highly likely they've got an alcohol use disorder. So the CAGE is meeting the criteria for what you would see if you were seeing an alcohol use disorder. Have you ever felt that you should cut down on your drinking? Have people been annoyed by you? Have people annoyed you by criticizing your drinking? And have you ever felt bad and guilty about your drinking? And the final one, which is, have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover, which is in essence self-treatment for withdrawal symptoms. So the CAGE, pretty easy, but when people respond positively to this one, one would consider with 2 question positive that they need a further assessment using the audit. But generally, if people are marking positive on the CAGE, they've got a pretty serious alcohol use issue. So a spectrum of unhealthy use. Risky alcohol use would be that the individual is drinking in excess of what is considered healthy alcohol use. Alcohol use has been discussed for years in terms of what is healthy, what is not healthy. The agencies who determine healthy, not healthy, depending upon who it is you're listening to, it's 1 drink of wine per day, which would be, for women, the maximum they could have in a week. For many other organizations, no alcohol at all is acceptable, particularly if the individual is pregnant. Problem use or harmful use or abuse, in which they run into other problems with this, and then finally on the spectrum is dependence that we've already talked about. The biggest issue to keep in mind is that this is a neurochemical change that has long-lasting effect even after the person's detoxed and the person's no longer using. Their endorphins, their natural endorphins, have been knocked offline by other substances which come in and take their place. That a chronic illness model is useful to consider when you're working with people, that people have periods of time when they do real well. When stressed, they may relapse to behaviors that worked for them in the past, because that's what everyone does when they're stressed. They go back to using things that used to work for them. Folks who have diabetes may go back to regularly eating things that they know they ought not eat. This is a similar situation. I have pickles on this slide for a particular reason. The concept, and this is not, I'm not the author of this, but I stole this from someone a long time ago, that once a pickle has changed, once a cucumber has changed into a pickle, they can't go back to being a cucumber. So it is useful to consider that once a person has crossed over into a use disorder of whatever, tobacco use disorder, alcohol use disorder, they can't go back to being the same as they were before they ever started using. Their brain has been changed and rewired forever. So the concept of staying away from substances altogether is a really good concept, because the fact that people are not going to think the same way because their brain has been rewired is helpful to keep in mind. So this particular concept, abstinence and risk reduction, because of the fact that people's brains have been rewired, that people have learned through over and over again behavior that some substances make them feel better, either through positive reward or negative reward, that they may say, I want to quit and not use anymore. And they may say that honestly and with great conviction. However, because their brain may be hijacked unconsciously, they may be receiving signals at a lower level that they're not able to perceive, and these perceptions at a lower level that is completely unconscious may hijack their brain enough below their level of awareness so that it drives them back to using without even attending to the fact of, how did I get this beer in my hand? I don't know how I got here because I never intended on drinking, and here I am. So recognizing the fact that this is sometimes below a person's level of conscious, helping people to plan on being successful is a good thing, but sometimes they need other help. So alcohol use disorders is a complex interaction between genetics, because alcohol use disorder is at least 50% genetics as well as environment, that there are multiple different types of alcohol use disorder, so it is not a one-size-fits-all treatment. And it has multiple biological targets, so sometimes when medication is chosen, that it works for one person and will not work for others, because alcohol use disorder is different depending on the person. So looking at what can we do to help people change, knowing that their brain can be easily hijacked, that alcohol can be used as a reward for positive reinforcement or negative reinforcement to make the pain go away. Sometimes as clinicians we may feel helpless to do anything different. So looking at Prochaska and DiClemente's model of trans-theoretical, it's a model trans-theoretical, we'll just leave it at that. Pre-contemplation occurs when a person is not even aware that they have a problem. And part of our job is to raise some doubt about the fact that maybe they do have a problem. So this would be useful in the senses that have people fill out your audit. You see, and to say, I'm looking at the responses to this particular survey that you did, and I want to give you feedback that you're drinking above the recommended limits of alcohol, and that I want to go over with you how much a drink is, what the normal limits are, and begin to raise some doubt with the individual. They may not have any decisions about the fact that they're wanting to change, but remember, part of our goal is to help people look at reducing the amount, because risk reduction is a huge part of this. So if you can get people to consider, well, if I drink one less, I'll still be fine, because as long as I can have one, I'll be all right, but I don't need to do 3, so I can cut back to 2, and that would actually be better because it would be less expensive. But the person has to make those decisions, but they have to get there. So pre-contemplation is that you're raising awareness of the problem. The person may agree, may not agree. It really is about planting the seeds of doubt, planting the seeds of doubt. So in review of what I just said, you're going to be non-judgmental about it, which in medical fields, it's hard sometimes not to be judgmental, because you feel like you should tell people in a way that suggests that you don't approve of their behavior. But realistically, that this is their choices, and being not judgmental, people will be better able to hear what you have to say. And if they say, I don't have a problem, it is okay to agree to disagree. I disagree with you because I'm looking at your liver function test and you're starting to have changes here. So I just want to let you know that this is something I'm concerned about. And I recommend that you either stop drinking altogether or cut down. So the last piece about this is that each time they come in, to follow up, even if they continue to use and don't change. The important thing is to say to folks, less is better. If you cut back even a little bit, and give positive rewards for the efforts that individuals are making to make the change, because change is hard, and acknowledging the fact that making the change is difficult. So contemplation is to tip the balance, to essentially kind of look at what it is about this activity that's positive and what it is about it that's negative. So to ask the person, so what about your drinking that's good? And to allow them to suggest the things that they like about their drinking. And then, so what's not so good? And the trick here is not to say what's bad, but to say what's not so good. What are the not so good aspects of drinking? And allow that individual to elicit what's not so good about their drinking. To be able to, at that point in time, in their verbalization of what's positive and what's not so positive, allows them to communicate verbally to you, which in the speaking has to require they think about what their behaviors are, and this begins to help with the change process. Again, you're going to advise. My professional advice is that you try cutting back, or that you stop drinking altogether. And part of this is to see how and what the problems are that the individual occurs in this process. Now action, and again, Prochaska and DiClemente's, some of the times people have forward motion, sometimes they have backward motion. It's all part of the process. It's never straightforward as going forward through all the steps easily. It's forward and backward and forward and backward. The main thing as providers that you keep saying to people, how are you doing? It's hard, I know. And so what are the things that you're doing that are good, and what are the things that are not so good that can continue to move the person forward? So people begin to avoid things that trigger off their use. They may reach out for help and take steps to avoid temptation. People may, again, have forward motion, and they may slip now and again. It is conceivable that that's part of the process. And maintenance phase in Prochaska and DiClemente is that they continue to do the behaviors and are successful in their process of changing. But even in a person who's in the maintenance phase, they have the potential to slip back into using again. So In the process of getting ready, they may make minor changes to support their goals, but they may not completely end unwanted behavior. So when you're working with people and they say, I can make little changes, keep moving forward. They may not completely end unwanted behavior, but this is about rewarding people for the efforts they're making. So getting back to looking at developing discrepancies, hopefully you can see this. These are some suggestions about what people might say in terms of the positive things about their drinking and the not so positive things about their drinking. And these are some examples of what people might say. So it is helpful to kind of reiterate back to the person that you heard them about what it was they're saying so that they can again hear what is coming from your mouth. So in terms of the readiness scale, this is also part of the MI, is to look at, on a scale of 1 to 10, how important is it for you to right now? And this is how important is it for you to change? How important is it for you to cut back on your drinking? And to elicit from the individual their willingness to move forward with this. Some folks may not want to move forward at all and may not even want to have a conversation about this, in which asking permission, can we talk about this? And if the person says, yeah, sure, then to kind of move forward with this because the person's ready to at least hear your thoughts on what it is that they can do. The tricky piece of motivational interviewing is to practice open-ended questions and to practice forming the questions so that you're eliciting from the individual thoughts that they have on particular issues, and for the provider not necessarily to give forth advice. This is not an advice thing, but to encourage the individual to make choices and to decide what they want to do about moving forward. So when they say for example, that on a scale of 1 to 10, that I'm 3 in terms of my desire to change at the moment. So the question would be, why did you choose a 3 and not a 0, which would be not changing at all? To give them a opportunity to respond to what their thinking was. And then, so what would it take to get you from a 3 to a 6? It understands about what they believe needs to move them forward with the process. And then asking about how confident they are is also another important part of the process. So if you decide to change, do you think you could succeed? When will you do it? It's establishing a timeline for the individual to decide when they're going to change. This is not unlike when you're helping people quit smoking, to establish a quit-by date so that it's clear when that person is going to quit. And this would be essentially the same kind of a consequence. So in summary, part of the MI is to elicit empathetic feedback, to ask permission when you begin the conversation, to ask the patient about what they think about the information that you've obtained from them about, for example, if they were drinking every Friday night 5 margaritas when they went out for happy hour, and they are newly discovering that this is exceeding the amount and considered binge drinking. What do they think about that? The advice part is you as a professional giving advice clearly that I as a health professional want to let you know that your drinking at this level increases your risk for developing certain types of cancers, certain types of breast cancer, for example, and that by drinking at this level, you're increasing your risk in that area. So helping people to set goals, to negotiate what it is that they may be willing to do, to talk with them about what options they have, which might be in terms of risk reduction, to look about as opposed to having 4 beers when they go out, to consider having a beer followed by a large glass of water, so that their ability to be social with people remains, but they don't necessarily have to have alcohol to be social. and to support their self-efficacy and follow up. So next time they come back in to ask, so how's it going? What are the things that you did well, and what are the things that you ran into problems with? So, in a nutshell, that's a little bit about SBIRT, but the bottom line that everyone always wants to know about is, can I get paid for this? And the answer to the question is yes. The codes that are listed on here are the codes that are available on a website that indicate that yes, indeed, you can be paid for screening individuals with brief intervention and be paid on a certain level. It's an add-on code, so should you be choosing to do that, you have that available to you, and that most folks like to be able to be rewarded for the efforts they make, and that is the reward to add this as a code onto your visit. So I have in this website a number of tools that you can use. There's a toolkit on sbirtonline.org that has many different tools in it. There are many available resources at SAMHSA, and so if you click on these links, they'll take you to those sites. If you don't have the links, you can just put in SBIRT or SAMHSA. SAMHSA has a wealth of information, and it's all free. So we've covered a lot of ground today. We've talked in particular about why it's important to use SBIRT in practice, to consider screening people when they come in. People's use of alcohol changes over time, that when people are stressed, they may use more. And so I'd like to leave you with the thought that you have the ability to help people have better lives, to reach them where they are, to accept them as they are, which is part of the motivational interviewing process, is to accept people as they are and to be there to coach them into their own personal goals, whatever they may be. So I'd like to take questions at this point.
This is everyone's opportunity. The email address and the phone number should be on your screen now. So if you have a question, just shoot us an email, give us a phone call. I have a question just to kind of kick us off. We've talked a whole lot about alcohol during this presentation. Is SBIRT just for alcohol, or could this be used for other substances as well?
Because alcohol is probably one of the most largest and most freely used in the United States, most of the studies were initially done on alcohol use disorders because people are coming into the emergency room for various behaviors related to their alcohol use. But over the last few years, SBIRT has been utilized successfully, although the studies are not as strong as they are for other substances as they are for SBIRT. It is easily applicable for tobacco use as it is for any other substance, but again, the evidence is not as strong as it is for alcohol.
All right. Is there one key thing that you hope that people leave this presentation with? Is there one point, if they got nothing else, that someone watching this, is there something that you really want them to know and focus on?
That would be that no one ever chooses to develop an addiction. They do the best they can, and sometimes the best they can is to figure out that this drug relieves them from the pain that they're experiencing, or somewhere along the line it does something for them. What it is individualized. But the issue is that because no one ever chooses that, is to, when you're approaching folks who've got a substance use, to consider this individual did not choose willfully to have this particular ongoing disability. I call it a disability because once their brain is hijacked, they may not make choices. They may choose things that are illogical based on the fact that the chemical is controlling their brain. So that would be what it is that to be non-judgmental, and as a healthcare provider to assist the individual to make choices, but to recognize the fact that people do die of substance use disorders, and they die fairly frequently. That as providers we do what we can, but unfortunately people die despite everything that we do.
That's all the questions I have. Are there any other questions that we have?
Dr.
Dr. Fogger, I have a question. Listening to you, it sounds like you're suggesting that any primary care provider or public health professional should use SBIRT every time they see a patient, and that makes great sense. I saw your codes that these things are reimbursable, but realistically, I can see providers saying, that's just going to take too much time out of my already really brief visit that I have with this patient. So as somebody who uses this on a daily basis, how long should it take someone in a primary care or public health setting to actually implement SBIRT?
In the sense is that the screening begins by asking one question. And the one question is how many times in the past year have you had X or more drinks in a single setting? That's a discriminating question in which they say, I've never had more than this. Then you might ask the audit C, which is the 3 questions, that if they're negative for both those 2 screens, that you're done. You've done your screening and you can move on. If they answer positively, then you would add additional screening. But realistically, SBIRT and the whole concept behind the brief intervention, the idea is that you can do it in a very short period of time. It can be done in 5 minutes. It is about planting the seeds and helping people see how they can choose to make changes in their life, to even make a deviation in the trajectory that their use is going. It is about helping people to look to see what they can do to reduce their risk.
Do we have any more questions? Okay. This concludes today's program. I just want to remind you that continuing education credits for this program are being offered through the Deep South Center and not ADPH. Please complete your sign-in sheet and evaluation and send both documents to Paulisha Holt at pholt@uab.edu. Please do not send this material to the ADPH office. Thanks so much for watching and have a great day.